we've established that the standard of care in second line has changed. It's now one of the 3 immunotherapy agents. We've established that in the first line setting, there's a small population that does better with immunotherapy. We've had some tantalizing data about combining immunotherapy with chemo. And the next wave of data sets that we're going to see over the next year or so are really fall into 2 categories. The first I'd like to talk about are the phase 3 chemo plus or minus immunotherapy trials. I think David alluded to the Keynote trial. I can't remember the number. That's really the follow-up of 21G. We have a number of trials with Atezo, and in fact, all the agents, or many of the agents, are in phase 3 testing.
Yeah, it's
chemo
going to be a busy year.
Yeah, and the question is, how's this story going to end?
I don't know. I mean, I think in the next 6 months, we will all be wrestling with results coming out, as you mentioned, with first line atezolizumab and bevacizumab and platinum-based regimens. We'll be wrestling with nivolumab and ipilimumab data.
That was the second camp, is the immunocombos.
Yeah, as well as durvalumab and tremelimumab coming out all in this late fall time frame. And it's going to be, what I spend probably too much time thinking about is, if all those hit, like, what would you use?
Right.
And that's difficult, because you want to see the data and how good it was and what are the toxicities that you pay for. But it could be an environment like that in a year from now, where we have multiple options in the first line setting.
You can only imagine how confusing it is to a community oncologist who doesn't focus on lung. It's just it's kind of crazy.
Well, a little scary too. Not that only we can understand how to deal with these drugs, but these immuno combinations can be
toxic.
A little bit hard to handle sometimes. And if you have all these things out there, I do worry a little bit about not the Wild West, but a lot of different toxicities that doctors aren't used to with just single agent checkpoint inhibitors.
And we've been very comfortable with platinum doublets for a long time. We've been very comfortable with adding targeted therapies to platinum doublets. In terms of managing them, like we say, most of the time it increases toxicity, but it's not prohibitive toxicity, and we can manage it. You start to get into the IO combos, and this is kind of forging new frontiers, so to speak. I mean, what are people's sense about in the first line setting? I think the first data set we'll see is the MYSTIC trial, which is single agent durvalumab versus durvalumab plus tremelimumab versus standard platinum-based chemotherapy. That'll be I think the first to read out. What are people's thoughts? Did anyone have any early predictions on that trial?
The other thing I'll just say and let you guys comment is, all these trials are designed to hit on every level. They have primary endpoints.
They don't want to lose.
They're stratified for PD-L1 high and negative, and so you don't know what scenario will be positive or not. But I'll let you guys comment on those trials.
Yeah, Ross.
Well, I think the durvalumab versus chemotherapy is kind of ringing bells whilst we had the positive, Keynote 024, we had the Checkmate 026, which was a negative study. And so, we
don't talk about that one.
Well, that's why I'm asking you the question. I talk about it, you don't talk about it. So the question is, what are the differentiating factors? Is it just the level of enrichment for PD-L1? But, tell me what you think about Keynote, because that, Checkmate. There were some issues other than just the PD-L1 level, right?
Yeah, there were issues. There's a lot of lesson in trial design, I think, in thinking about Checkmate 026. We only used 2 stratification factors. There was an imbalance in known prognostic factors, female sex, presence of liver metastases, that were favoring the chemotherapy arm, so that performed better than average. If you look at the overall survival and Kaplan-Meier curves, both arms had overall median survivals of about 14 months, just shy on both sides. And those survival curves look completely superimposable. So, usually in lung cancer, 2 drugs beat a single drug. Here we have a situation where you can argue in a relatively unselected population, meaning greater than 1%, that's the majority of patients, we have a single agent that looks very similar to a platinum-based doublet. But at the end of the day, it was a negative trial, and it brings up the issue You know, I've kind of, I kind of look at this like I look at the EGFR TKI story, using it in initially wild-type populations, where you know, unselected populations where we knew that the majority of patients were wild-type, not getting substantial benefit, but there were these patients in there that might be driving whatever benefit you would have seen. But then when we isolate those patients, you know, akin to Keynote-024 with the high expressors, you see the real value of the drug in that population. And then I think in Checkmate 026, we just didn't enrich enough. Yeah. Plus you add a few bad luck things like the imbalance in female sex, which is a known prognostic factor.
But you know, Ross, I don't know what to guess on which one, you know, would that be Mystic be positive or Neptune be positive or not? I mean, it was a different...
Checkmate 227 is a similar design with Nivo-Ipi.
The differences between 024 and 026, Checkmate and Keynote studies, has made me, you know, not confident to try to guess which of these trials will be positive.
Right, right.
I won't guess which are positive, but I will guess how the bars will be set by the oncologic community. Just as there may be a culture against drugs like, say, bevacizumab, I think there is a very strong cultural tidal wave in favor of immunotherapy, and in particular for immunotherapy without cytotoxics. And so I think compared to some of the other conversations, I think the bar is going to be lowered a little bit, and people are going to be looking in the broader community for how to look at these combination immunotherapy trials positively.
Although you'll have probably 6 months of, maybe a year's worth of experience of carbo-pem-pem, and a lot of comfort there, I'm guessing.
Right.
You know, and then you start talking about CTLA-4 combinations. I mean, doctors might still be most comfortable with a carbo-pem backbone.
Yeah, so I guess the question is, how does the panel feel, you know, if you had to place a bet today? Are you betting on adding immuno to chemo, because that's kind of our comfort zone, or are you betting on the immunocombo strategy with the two regimens that we have out there?
I'm betting on the path of least resistance, which is people will start to use pembro in combination with chemotherapy and not worry about PD-L1 testing.
Yeah.
And I'm not saying scientifically that's valid, but I think that's what most people will do.
Others?
I think the Nivo, Ipi, and Durva-Tremi trials, something's got to hit. Like, there's too many endpoints that are powered to show some difference. And every study so far has confirmed, even in melanoma, that the response rates are higher.
Right.
The toxicity is higher. Whether that translates into a PFS benefit and an OS benefit, I mean, you may not have to even meet an OS, just a PFS benefit is unclear, but I probably would bet on the combinations.
Immunocombinations.
Immunocombinations.
Yeah, okay.
Yeah, I think I'd bet on that too. And I think a lot of it depends on goals of care here too. You know, I think there's such a push away from chemo. And it's like, you know, it's like a win if you can do something without chemo. And I see that trend continuing, I really do. And I think that's what's going to happen.
Right.
My money would be on the immunocombinations. And people are going to, you know, I forgot, there's a name for the term where you tend to believe the data that supports your belief.
Yeah.
You know, and that's what people are going to do.
It's called echo chambering.
Yeah.